The endocrine system is one of the major control systems in our body. The nervous system is another one, and we will talk about the nervous system in great detail in the winter. So we'll leave that for now, but we'll talk about the endocrine system. So the two major endocrine effects that we are going to largely encounter in physical therapy are effects of diabetes mellitus specifically, and the effects of osteoporosis. So osteoporosis is a complex disease, but calcium metabolism is largely controlled by hormones. So we'll talk a little bit about them. We'll talk a lot about diabetes and recommendations for those, and then we will touch on some of the other endocrine disorders. So endocrine glands are located throughout the body. So the hypothalamus is in the middle of the brain, and it is a large part of the endocrine system. The pituitary gland, also in the brain. The pineal gland in the brain. Two adrenal glands, which are on top of the kidneys. The thyroid gland, which is sort of in the throat area. The four parathyroid glands, which are tiny and attached to the thyroid. The endocrine portion of the pancreas, so there's a digestive portion and an endocrine portion. The testes in the male and the ovaries in the female, and the thymus, which is sort of mid-chest. So there are also local hormones secreted in the digestive tract that regulate a lot of the digestive capabilities and effects, and we'll talk about them a little bit in the digestive chapter. So endocrine glands secrete hormones directly into the bloodstream, in contrast to exocrine glands that secrete into a duct or inside an organ, like mucus, serous glands, sweat glands, digestive enzymes. So the endocrine system, the gland that is secreting the hormone might be far distant from the place where it has an effect. So basically, hormones are chemical messengers. You can classify them by their action, by their source, by their chemical structure. There are lots of hormones that affect blood glucose levels. In the book, there's a whole list of hormones classified by source. Basically, they are released into the bloodstream, chemical messengers, and there are target receptors in different tissues that have some kind of effect, and most of the time it's a negative feedback system. There are two different chemical structures that you'll see for hormones. Peptide hormones, like insulin is a peptide, and steroid hormones like testosterone and estrogen are steroid hormones, and cortisol. So the hypothalamus, it releases a lot of different hormones, like antidiuretic hormone to control our blood pressure, also known as vasopressin. It releases oxytocin. They're both produced in the hypothalamus, and they're transported to the pituitary gland, where they're stored and released upon the appropriate stimulus. So the pituitary gland releases a lot of hormones: human growth hormone, prolactin, follicle-stimulating hormone, luteinizing hormone, thyroid-stimulating hormone, and adrenocorticotropic hormone. Sometimes the pituitary is called the master gland. A lot of times, overgrowth syndromes are caused by pituitary tumors. Humors. Anyway, the thymus works a lot in producing immune system cells. So thymosin and thymopoietin are producing those white blood cells that act in the immune response. So the thyroid, it produces thyroid hormone and calcitonin. Calcitonin is a big one for calcium metabolism. And thyroid hormone has an effect on our metabolism. So it speeds it up or slows it down, depending on what has to happen. Parathyroid gland releases the parathyroid hormone, which is sort of the opposite of calcitonin in calcium metabolism. So we'll talk about that a little bit. The adrenal cortex on top of the kidneys releases glucocorticoids, which we know function in inflammation, gonadotropins, and mineralocorticoids. So there are lots of different functions that those have in the body. The adrenal medulla releases epinephrine and norepinephrine, which are big neurotransmitters. So epinephrine and norepinephrine can act as hormones, they can act as neurotransmitters, they can act as neuromodulators, so they have a lot of function in the body. And when we're talking about neuro next in winter quarter, we will talk about the difference between a neuromodulator and a neurotransmitter. Let's just say that it has a lot of effects. So the pancreas, really big in the exocrine area in digestion, also big in the endocrine area. It releases insulin, glucagon, and somatostatin, which are all things that help regulate glucose metabolism and lipid metabolism. The pineal gland releases melatonin. It's helpful in our sleep cycles. The ovaries release estrogen and progesterone, and the testes release testosterone. So all of the, like we talked about in the aging chapter, all of the hormone glands except the ovaries and testes produce a reasonable amount of hormones, a regulated amount of hormones throughout your life cycle. Your tissues just become less sensitive to the amount of hormones being released. The ovaries and the testes actually decrease the amount as you get older. I talked about there being steroid hormones and non-steroid hormones. So the steroids are lipids. They enter the cell and the nucleus, and they act directly on the nucleus to engage in transcription, making RNA. So hormones are part of the things that control that genetic expression that we talked about in the genetic chapter. And so what turns on and off genetic expression? Sometimes it's a hormone messenger. The non-steroid or peptide hormones need a second messenger system to activate the formation of messenger RNA. So after they're released from the gland, the hormones circulate to the target cells and other glands or tissues, and after acting on specific receptors or in the nucleus of the cells, they're metabolized or inactivated by the target tissues or the liver, and they're excreted by the kidneys to prevent excessive amounts from accumulating in the blood over a period of time. So there's a table, and it's so tiny here you just can't read it, but in the book on page 404 it's bigger and you can read it there. The major sources of hormones and their primary effects. So it's just interesting. I'm not going to quiz you on all these, but you had it in A and P, and it's interesting to see the ones that we really care about on a day-to-day basis are usually insulin and in terms of PT, because it's going to affect someone's performance in PT. So the release of hormones from glands is mostly controlled by negative feedback mechanisms. So as the glucose level increases, the secretion of insulin increases. When glucose levels decrease, insulin secretion decreases. So there's a direct effect on the target tissues, basically. So endocrine and nervous systems work together to regulate our metabolic activities. Some hormones have a super complex system, like the hormones that regulate our blood pressure, the antidiuretic hormone and the vasopressin and the aldosterone cycle. It's pretty complex, and the secretion can be controlled by more than one mechanism. So the rate and timing of secretion may vary. Like you could have cyclic patterns. Like with estrogen and progesterone, they have a cyclic pattern. And with melatonin, that has a cyclic pattern, controlling our circadian rhythms and when we sleep and when we wake. So, and then some of them are just sort of secreted in response to other things. Like we eat food, there's more sugar in our blood, that causes more insulin to be secreted. Sometimes it's in a reaction to something, sometimes it's a cyclic pattern. So with endocrine disorders, all of them reflect impaired control or feedback. So a lot of times, we talked about this in the cancer chapter, how a tumor can start increasing an excessive amount of hormones, producing really high levels. And then getting rid of it by the liver or kidney is impaired. Sometimes congenital conditions produce excess hormones, resulting in different effects depending on what the hormone is. So usually it's, with endocrine disorders, it's either hyper or hypo. Excess hormone levels are hyper. So if you have hyperthyroid, you have excess thyroid levels. If you have hypothyroid, you have too little. So you have a deficit. So sometimes a deficit of a hormone is produced by a tumor that isn't producing hormone because it's the tissues are defective in the tumor. It could be that inadequate tissue receptors are present, so even though the hormone's there, we don't have the receptors to make use of it. So that's one of the things with aging, is we have fewer receptors. There might be an antagonistic hormone that is preventing that one from helping, like the parathyroid and calcitonin. They're antagonistic hormones, so they kind of have to fight it out and see who's going to win. That happens a lot in the nervous system too. There's some there's inhibitors and exciters, and sometimes they have to fight it out and see who's going to win. Malnutrition can cause a deficit of hormone because you don't have the raw materials to build it. Atrophy or surgical removal of a gland. Sometimes if people have thyroid tumors and those get removed, unfortunately the parathyroid gets removed at the same time because it's little and it's right on the surface of the thyroid, and it's hard to miss it when they're taking out the tumor, and that results in a parathyroid hormone deficiency. Or sometimes there's a congenital defect that you're just not producing active hormones. So people who have type 1 diabetes, it's an autoimmune disorder that controls the insulin producing cells in your pancreas, and so you're just not producing the insulin. With type 2 diabetes, and we'll talk about these in the next section, but type 2 diabetes, you're producing the insulin and it's the correct amount, but the receptors aren't as susceptible to it. So hormones can be tested by blood tests to check serum hormone levels. They can do radioimmunoassays where they tag certain, they have a radio tag on certain things, like they can have radio tagged iodine and track it through the thyroid, or they can use immunochemical methods to tag different hormones, and they can see how they're functioning in the body, which is pretty cool because that's really only been in the last 15-20 years or so that they've been able to do those. Some of them show up in urine tests. Some of them show up in stimulation or suppression tests, so they'll be given certain drugs to stimulate or suppress, for example, thyroid function or adrenal cortical function. Scanning, like CAT scans, ultrasound, MRIs can show up if there are tumors or those kind of abnormalities, and then a biopsy looking for those defective cells that are either producing too much hormone or not enough. So a lot of times a hormone deficit is treated with replacement therapy. So if somebody has had to have their thyroid removed for whatever reason, they will be on a thyroid replacement. sometimes we'll talk about some of the other things that are treated by replacement therapy. Excessive secretion is sometimes treated with medications, surgery, or radiation. So sometimes somebody is suddenly losing weight. That's one of the warning signs of potentially having cancer, right? So suddenly you have this unexplained weight loss. Sometimes it's a tumor in your thyroid that needs to be removed that's producing excess thyroid stimulating hormone, which increases your metabolism and you lose weight. Sometimes, and it can be treated by surgery or radiation or sometimes medications. So you have to see what the cause is before you see what the treatment is going to be. So patients with diabetes or osteoporosis represent the primary patient population that receives PT intervention. For other patients with endocrine or metabolic dysfunction, the primary physical treatment guidelines are these. So in PT, we always want to improve activity tolerance. We want to make sure people can do what they need to do to live their normal lives. So say somebody lives in a house and they have to walk 150 feet to be able to get from their bedroom to the bathroom to the kitchen. Well, they have to be able to tolerate that amount of activity. So that's a legit thing to treat somebody in physical therapy for. It might be necessary to decrease their exercise intensity when the patient's medication is being adjusted. So someone with insufficient thyroid hormone replacement will fatigue more quickly than someone with adequate thyroid hormone replacement. So knowing the normal values of the thyroid hormone and reviewing the laboratory tests helps the therapist gauge the appropriate treatment intensity. So if you, say you looked at somebody's labs and they had a low hematocrit, which means the percentage of red blood cells is lower, they're going to fatigue more easily. Same thing with thyroid hormone. If they have abnormally low values for thyroid hormone, they're going to fatigue more easily. And so we are going to use that information to help adjust our treatment intensity. Sometimes, especially if you work in an inpatient setting, you're going to consult with a nutritionist to help determine the appropriate activity level based on the patient's caloric intake. Because caloric intake and metabolic processes are affected by endocrine and metabolic disorders, it's really important that you coordinate with the other members of the healthcare team to make sure that you're not over or underworking people. I used to work in a skilled nursing facility, and the nurses would get pissed if we would take people to the gym to work out before they had their medication. Because exercise acts like insulin in terms of metabolizing blood sugar. And so we get these people showing up to dinner. A lot of times the nurses are taking their blood sugar level right before dinner to see if they need insulin. And they'd be showing up with really low blood sugar. So coordinating with the rest of the healthcare team makes a big difference in the success of the treatment for our patients. The other thing, you can work with the other members of the team, particularly the nutritionist. If you have someone that isn't able to do their normal transfers and their normal self-care activities because of their fatigue level, it might be that they have inadequate caloric intake because of their certain issues. And you can work with the nutritionist to get them on the right program so then they are able to be more independent. So it's great to work in a setting where you have the rest of the healthcare team there to coordinate things. If you're working in an outpatient setting, you can work closely with your patient to help coordinate these really important treatments.